Now, I am a pharmacologist and this is my bread and butter. Uh, but I can tell you, even in my final year MD, I did not know what is a time dependent and a concentration dependent antibiotic, because I did my MD now 15 years ago. Even that time, the only differentiation was bactericidal, bacteriostatic, broad spectrum, narrow spectrum. We were never given this sense that the clinically the most important distinction in antibiotics is time and concentration dependent. Okay, so let's try to learn this. MIC is minimum inhibitory concentration, and by default we mean MIC 90, which means minimum concentration needed to inhibit 90% of bacteria. Okay, whenever we give any drug, its level has to reach at least the MIC concentration for it to be effective. Okay, now there is something known as a therapeutic window between MIC and toxic dose. The normal dose and the toxic dose, the window between that is the therapeutic window. Now, what is the difference between side effect and toxic effects? Side effects or adverse effects are those which happen because of the dose given within the therapeutic window. If you take aspirin, you have acidity. This is normal adverse event. If you take 10 aspirins, 20 aspirins, you may have hepatic failure. That's a toxic dose. That's a toxic effect. Okay. So someone asked Swami Vivekananda, what is a poison? He said, anything in excess is poison, which is so true here. He explained therapeutic window in a way. Okay, so we have to know this. Drug is a poison or a placebo will only depend upon the dose. Dose decides it. If you give too small a dose, the levels will not even reach the MIC. So it's a placebo. Bacteria will eat, enjoy. If you give too high a dose, it will become toxic. So a drug is a drug only if given in a particular dose. Okay, let's see this. So MIC, minimum inhibitory concentration. This is known as highest concentration Cmax. The area in the green is bioavailability, the amount of drug which is actually available at the site of action, or the serum concentration. So as I said, the three parameters, Cmax to MIC ratio, AUC, which is the bioavailability to MIC ratio, and T more than MIC ratio. That's how the whole PK/PD terminology is. And there is something known as a post-antibiotic effect. Okay, now let's study this in detail. For starters, let's remember this list of drugs which are time dependent and lists of drugs which are concentration. All beta-lactams, PCMC you see here are time dependent. Fluoroquinolones, aminoglycosides, even your colistin, these are concentration dependent drugs. Now let's see what happens. Okay, let's see this. Suppose this is a meropenem. In a time-dependent drug, if I give meropenem 30 minutes infusion, it remains above MIC, which is the dotted line here, only for 30 minutes. See, only for 2 hours, it remains above the MIC. After that, the levels come down, and then you have to give the next dose. If for the same drug, I give prolonged infusion, 3 hours infusion of meropenem, imipenem, piptazo, the same drug now remains above MIC for at least 4 to 5 hours, and then the next dose will be due. So during the interval of 2 doses, the endeavor is to keep the levels above the MIC for as long as possible. Minimum should be 50, 40, 50% of the dosing interval. What is the meropenem dosing interval? 8 hours. What is 40% of 8 hours? About 3.5 hours. So at least for 3.5 hours between the 2 doses, the levels have to be above MIC. How do we do that? Giving prolonged infusions. Okay, that is the principle for time-dependent antibiotics. Okay, so if you are giving ceftazidime, piptazo, carbapenems in a sick patient, give in prolonged infusions. Carbapenems cannot be given longer than 3-hour infusion because they are unstable at room temperature. But piptazo you can give up to 6 hours. Okay, ceftazidime, Fortum can be given up to 24 hours. So please remember that for time-dependent antibiotics, clinically how we can improve their efficacy by giving them in prolonged infusions. On the other hand, concentration-dependent antibiotics means higher you go above the MIC, more is their efficacy. And how you can achieve the higher Cmax? single shot. I often say it's a crime to give levofloxacin 250 mg BD or TDS in a sick patient. The right dose of levo is 750 mg single shot. For amikacin, gone are the days when you used to give 100 mg per kg TDS. Right dose is 15 to 20 mg per kg single shot. Okay, because we need to hit hard. For concentration dependent antibiotics, higher the concentration above MIC, more is the killing effect. Now you will ask, but what will happen if I give very high dose? It will go up and then come down. But the next dose is available only after 18 to 24 hours. That is where the post-antibiotic effect comes. For concentration-dependent antibiotics like fluoroquinolones and aminoglycosides, even when the concentration falls below MIC, PAE, post-antibiotic effect comes in, which means bacteria still remain, the remaining bacteria still remains stunted. They do not start regrowing for a considerable period. And when they start regrowing, there is a time for the next dose of it. Okay, that is how concentration-dependent antibiotics work and the time-dependent. Remember this one slide. For time-dependent, give prolonged infusion. For concentration, maybe single shot or maybe maximum 2 shots in high dose. Okay. Now let's see, are we ready for MIC-based PKPD dosing? Let's look at this case of extremely drug-resistant Pseudomonas. Okay, let's see this case. 60-year-old diabetic, past history of hospital admission for UTI 30 days back, admitted in ICU with myocardial infarction, put on ventilator. On day 5, developed signs and symptoms of BAP. Started empirically on peptaz, 4.5 grams TID in 30 minutes infusion and levofloxacin 500 mg PD. My first question, do you see anything wrong with the dosages given here? Any answers? Anything wrong in this empirical therapy in dosage?
Levoflox.
Right. One is levoflox should be 750 mg and second peptazo should be 4 times a day. It's a time dependent. We should not reduce the frequency. May I request someone to put the mute? There is a lot of disturbance. Thank you. The correct dose of peptaz is 4.5 grams.
बाबू ओ भैया किट्टू दीदी को बर्थडे में नहीं जाना है बाबू बर्थडे में जाना है बेटा
Okay, the correct dose of peptaz is 4.5 grams 4 times.
Diaper change.
डायपर तो कर ही रही
Dr. Mohan, may I request to mute?
बर्थडे में नहीं जाएगा भैया
Okay. So peptazo is a time-dependent antibiotic. The correct way to give is 3 to 4 hours infusion and also 4 times a day. And levofloxacin is concentration, so single shot. Okay. Now suppose you get this culture report after 48 hours. Pseudomonas resistant to almost everything. Only colistin is sensitive. What to do next? So physician stops peptazo levofloxacin, starts colistin 2 million units twice a day. Is this the right approach? Yes or no?
No.
Why?
Loading dose.
What is the loading dose for colistin?
9 ml.
9 million to 12 million units. Okay. Second, should he be giving colistin alone?
No. Bacteriostatic drug.
What to add with colistin? Okay. First of all, now we very clearly know there is something known as heteroresistance in colistin. What is heteroresistance? The first few days, the pathogen is sensitive, but after a few days, the same pathogen becomes resistant to colistin. That's heteroresistance. Okay, it's very common. To prevent heteroresistance, we have to give a combination. Right? So first thing, as you rightly said, the correct dose of colistin should be 9 to 12 million units loading. Even if the patient is renally compromised, give the loading dose at least. The maintenance dose then can be adjusted as per the renal parameters. Okay. Now, so we have got the right dose of colistin. Now, how should we add the second drug to colistin? And see this for this colistin, this was amazing graph. If you give 2 million TDS, it reaches its MIC of 2 after 48 hours. And this patient is sick. If you give colistin low dose, bacteria are only tasting, it's a placebo. Only if you give a loading dose in the first half hour, the levels cross 2. Such a telling graph to tell you that even a drug like colistin will be useless if we do not give it in the right dose. Okay. Now, and this is again, if you can, I'm going to give this slide. So this, I'm sure all of you know how to reduce the dose of colistin as per the renal impairment. Okay. And now there is clear data. Higher the dose given, lesser is the mortality. Okay. Now, how will you add a second drug to colistin? I think if everything is resistant, you should tell the microbiologist, ma'am, please don't give me SI or R, sensitive, intermediate, or resistant. Tell me the actual MICs. So please ask for actual MICs from your microbiologist. Now, in that case, suppose imipenem, meropenem, whose MIC, what is the breakpoint? Imipenem, meropenem for Pseudomonas? 4. Anything more than 4 is resistant. But if imi and mero are 8, MIC is 8, which means it's not very high, it is still intermediate. You can combine imi and mero in prolonged infusion, high dose with colistin. Okay? That is how MIC, knowing your microbiology, will help you in pharmacology. If imi mero MIC here was 64, I know even by giving 6 grams per day meropenem, 3 hours in infusion, I cannot achieve a level of 64. I have to look at some other drug. But if the MIC is between 8, 12, 16, very much so, I can increase the dose, prolonged infusion, and add with colistin. So the same drug, imi-mero, given in the right dose, will help even in mildly resistant or intermediate resistant pathogen. So please, knowing MIC is very important in critical care in resistant pathogens. So I'll say PKPD makes good drugs look better. Okay. The same imi-mero would have been useless if you use in the normal dose in resistant pathogens, but can become useful if you know your MIC and jack up the dose. Okay. Remember this algorithm. Pathology and epidemiology, you know what is the patient's primary diagnosis. Ask for MIC data. Is the organism highly susceptible? If yes, use normal dose. If the organism is not highly susceptible, that means SR, obtain an MIC. Routine SIR is insufficient. Then adjust the dose based upon PKP. If the pathogen is totally susceptible, you can use normal dose of imi-mero, okay, or piptazo or any other drugs. But if it's resistant, then ask for MIC, and based upon MIC, use your PKPD principles. Okay, and this is just a summary table for you to remember that which drug, what is the parameter for different drugs, how should you give the first dose? Usually the first dose is the highest possible dose, and then what should you do in a renally impaired patient according to the drug. Okay, let me stop here because now I'm going to go into the how to make a clinical protocol, how to make treatment guidelines in your hospital. Any questions on kinetics and dynamics?